Sagar, and today I'm going to talk about bronchiolitis and bronchitis. And I'm doing my residency in pediatric, so that's why I'm going to discuss on most common respiratory disease, bronchiolitis. So before starting the bronchiolitis, let me discuss about the wheezing, the production of musical continuous sound that originates in narrowed airways or on expiration. As a result of airway obstruction, infants more likely to wheeze than older children. So obstruction of airflow affected by the size and compliance of the lungs. R is directly proportional to 1 by R upon R4. R is the resistance and R is the radius. That is, decreased radius increases the resistance of airflow. So pathophysiology of wheezing. Children younger than 5 years of age, they have a small diameter peripheral airways that contributes 50% of the total airway resistance, and additional narrowing leads to wheezing. The high lung compliance, normal expiration causes airway collapse. So difference in tracheal cartilage and airway smooth muscle tone increases the collapsibility, and the results with normal growth and development. So acute bronchiolitis, it is a diagnostic term, describes clinical picture produced by several different viral lower respiratory tract infection in infants and very young children. The most common cause is the respiratory syncytial virus, which is 50% of the cases, and other are metapneumovirus, rhinovirus, parainfluenza, influenza, bocavirus, adenovirus, and the viral co-infection. In fact, the severity rarely followed by bacterial co-infection. And the risk factor for bronchiolitis are the common in male exposed to secondhand tobacco smoke, living in crowded condition, infant or mother who smoked during pregnancy, not breastfeed, and source of infection, older family member, sibling with minor upper respiratory tract infection. So now the pathophysiology of bronchiolitis. First of all, the viral infection of the lower respiratory tract, which leads to bronchial obstruction due to edema, mucus, and cellular debris, and that will lead to resistance of the airway increase, inspiration and expiration, and further the expiration further narrows the airways and increase the resistance and expiratory wheeze. So obstruction trapped air in the distal airway reabsorb the air, resulting atelectasis, and there is hypoxemia, ventilation perfusion mismatch with severe obstruction resulting hypercapnia. So again, the pathophysiology. So clinical manifestation, if there is exposure to contact with flu symptoms with previous week, the age infants is 1 to 6 months, but affect up to 2 years, and the mild upper respiratory tract infection with sneezing and clear rhinorrhea, diminished appetite and fever of 38.5 to 39 degrees centigrade. Gradually respiratory distress develop with paroxysmal cough, dyspnea and irritability. Often there is tachypnea which can interfere with feeding, and apnea may be more prominent early in the course of the disease, particularly with very young infants less than 2 months or former premature infants. On examination, there will be tachypnea, fever, nasal flaring, retraction, wheezing and crackles, prolonged expiration, hypoxia, and the lack of audible wheezing is not reassuring if the child or infant shows other signs of respiratory distress. And poorly audible breath sounds suggest severe disease with nearly complete bronchial obstruction. Now the diagnosis. The clinical diagnosis, particularly in a previously healthy infant presenting with first time wheezing episode following the upper respiratory tract infection. On chest radiograph, not routinely indicated. However, the areas of atelectasis difficult to diagnose from the bacterial pneumonia, and there is revealed hyperinflated lung with patchy atelectasis. Other diagnostic testing usually not indicated. The viral testing, PCR, and the rapid immunofluorescence also not routinely recommended. So the treatment. Before the treatment, going to hospitalize. If there is a respiratory distress in the form of hypoxia, inability to take oral feeding, apnea, extreme tachypnea, risk factor for the severe disease are the preterm birth, underlying comorbidities such as cardiovascular, pulmonary, neuromuscular diseases. On treatment, generally the treatment is only supportive, and if there is hypoxemic, cold humidified oxygen for hypoxemia, high flow nasal cannula reduce the need for intubation in impending respiratory failure. The target oxygen saturation will be more than 90%, and supplemental hydration and frequent suctioning of nasal and oral secretion. On treatment, pharmacology, there is not exact drugs, but however, the use of beta adrenergic agonists like albuterol or even steroid has not been shown to be effective, and response to bronchodilator in infants unlikely and unpredictable. Use of hypertonic saline. Most studies meta-analysis fail to demonstrate any benefit, and the racemic epinephrine may reduce the risk of hospitalization when used in outpatient setting. The ribavirin targeting the respiratory syncytial virus also not currently recommended due to minimal impact on disease outcome and is costly, difficult to administer, associated with toxicity. So on treatment, the viral bronchiolitis, there are the categories of mild, moderate, and severe. In mild, normal ability to feed, little or no respiratory distress, no hypoxemia, does not need investigation or home treatment. And moderate respiratory distress, mild hypoxemia, brief apnea, shortness of breath, then admit the patient with humidified oxygen to keep saturation more than 92%, and IV fluid, adrenaline or hypertonic saline trial, observe for deterioration. In severe bronchiolitis, severe respiratory distress, apnea or hypoxia, looks tired and cannot feed. So admit the patient and ICU care, oxygen keep saturation more than 92%. In IV fluid, adrenaline or hypertonic saline trial, and the cardiorespiratory monitor, arterial blood gas analysis, chest X-ray, assess for ICU and ventilation. If there is improvement in moderate bronchiolitis, then decrease the oxygen guided by a saturation, and reestablish the feeding and discharge when the feeding well and distress less. If there is deterioration, same as the treat as the same bronchiolitis, severe bronchiolitis. On prognosis, the highest risk for further respiratory compromise in the first 72 hours after the onset of the cough and the dyspnea. The case fatality rate is 1%, with death attributable to apnea, respiratory arrest, or severe dehydration. The majority death in case of complex medical condition or comorbidities like bronchopulmonary dysplasia, congestive heart failure, or congestive heart disease, and immunodeficiency. The mean duration of the illness is 14 days, and 10% are asymptomatic for 3 weeks. The severe lower respiratory tract infection at an early age has been identified as a possible risk factor for development of asthma. In prevention, the meticulous hand hygiene is the best measure to prevent the transmission of the virus. The administration of palivizumab and monoclonal antibody to respiratory syncytial virus that reduce the risk of hospitalization and does not decrease the mortality and does not protect against bronchiolitis caused by other viruses. And the indication of this drug is child or children born at less than 29 weeks, completed gestation, or with significant heart disease or chronic lung disease of prematurity through the first or second year of life, neuromuscular disease, and immunocompromised state. Thank you.